Welcome to AETCM, the emergency medicine channel. Today let us discuss about Hodgkin's lymphoma. Hodgkin's lymphoma is one of the common type of lymphomas. If we take the classification of lymphoma, you can see two major classic types of lymphomas are Hodgkin's and non-Hodgkin's lymphoma. Lymphoma means malignancy of lymph node. It is not the malignancy of bone marrow, it is the malignancy of lymphatic system and lymph node. So, the malignancy arising from the lymph node, it can spread to other organs in our body. It can even spread to bone marrow afterwards, but the malignant cells will not be there in the peripheral blood. That is the difference between lymphoma and lymphatic leukemia. There are two important types, Hodgkin's and non-Hodgkin's. There are other types of lymphomas also present in lymphomas, but major two classifications are Hodgkin's and non-Hodgkin's. Male to female ratio is 1.5 to 1. That is a male to female ratio. There is a bimodal age incidence for lymphoma. Peak age, first group is 20 to 30 years. Next peak age is 50 to 70 years. So, two age group of patients can have lymphomas. So, we have already seen that the major difference between lymphoma and leukemia is the difference in the peripheral bloodstream. Peripheral bloodstream, you don't get malignant cells in lymphoma, but in leukemia you get peripheral bloodstream malignant cells or atypical cells, whereas bone marrow, lymph nodes, spleen, liver, everywhere you can see both. But peripheral blood as such, lymphoma will not be producing any malignant cells. Now, if we see the difference between non-Hodgkin's and Hodgkin's, any age non-Hodgkin's can occur. Non-Hodgkin's, any age, and Hodgkin's, that bimodal distribution we have seen in the previous slides. Alcohol induces pain in the nodes in Hodgkin's lymphoma. B symptoms are more common in Hodgkin's lymphoma. And adenopathies, classically it is mainly seen in localized lymphadenopathy in Hodgkin's, but it is generalized initial itself in non-Hodgkin's. The difference we should understand, after the initial period, Hodgkin's also behave like non-Hodgkin's in lymphadenopathy distribution. So, initially it will be localized, unifocal, axial nodes are involved mainly, so that middle part of the body is involved mainly, whereas in non-Hodgkin's it is extra axial nodes also involved, like Walde's ring, spleen, liver, all these things are involved early itself. So, axial lymphadenopathy is classically seen in Hodgkin's initially, whereas extra axial involvement is classically seen in non-Hodgkin's initially. Afterwards, later this will become, we cannot differentiate in clinical features with along this axial and extra axial nodes. Hepatosplenomegaly is seen early in non-Hodgkin's, late in Hodgkin's. Bone marrow involvement, early involvement in non-Hodgkin's. Hodgkin's, it is late involvement. Lung brain involvement early in non-Hodgkin's. Hodgkin's, it is late. So, it is something like this. Hodgkin's is a limited disorder. It limited to some group of lymph nodes and mediastinal nodes, abdominal nodes, like that it is limited, whereas non-Hodgkin's initially itself it spreads everywhere, axial, extra-axial, spleen, liver, bone marrow, brain, everywhere it spreads. But after sometimes, if you don't treat Hodgkin's, it also behaves like non-Hodgkin's lymphoma. So, here you can see lymphatic organs in our body. So, you have cervical lymph nodes, lymphatics of the mammary gland, thoracic duct, thymus, cisterna chyni, axillary lymph nodes, spleen, lumbar lymph nodes, pelvic lymph nodes, lymphatics of the lower limb, inguinal nodes, lymphatics of the upper limb. Then you have other organs also. Other lymphatic organs also. So, the Hodgkin's lymphoma mainly affects the central part of the body, whereas non-Hodgkin's involves the peripheral part of peripheral lymphatic part of the body. But after some times, this differentiation will be lost. So, everywhere all lymphatic tissues will be involved in later phase. in both Hodgkins and non-Hodgkins. Ball-Dyes ring classically initially itself involved in non-Hodgkins. Later it can be involved in Hodgkins also. Now one peculiar cell, that is Reed-Sternberg cell. It is a classical finding in Hodgkin's lymphoma slides. If you are examining the biopsy slide of Hodgkin's lymphoma, you can see the Reed-Sternberg cells. It's a large 30 to 50 microns and either multinucleated or have bilobed nucleus. That is a classical finding. Bilobed nucleus. It's called as All's eye appearance. So these cells are of follicular center B cell origin. So you can see the slide here. In that all cell appearance or bilobed nucleus can be seen, visualized. That cell is called as Reed-Sternberg cells. These cells are pathognomic of Hodgkin's lymphoma. Now we can classify Hodgkin's lymphoma according to the pathological feature of lymphoma, classical lymphoma and nodular lymphocyte predominant Hodgkin's lymphoma. Again, classical lymphoma you can classify into nodular sclerosing classic Hodgkin's lymphoma, mixed cellularity, lymphocyte rich and lymphocyte depleted. So this is the classification of Hodgkin's lymphoma, whereas non-Hodgkin's lymphoma, it is classified into indolent or low grade, slow progressive, for example follicular lymphoma, aggressive or high grade, rapid progression, diffuse large B cell lymphoma, Burkitt's lymphoma. These are the classification for non-Hodgkin's lymphoma. So basically lymphoma is classified into Hodgkin's, non-Hodgkin's. Hodgkin's is classified into classical and nodular lymphocyte predominant Hodgkin cells. In classical, again nodular sclerosing, mixed cellularity, lymphocyte rich, lymphocyte depleted. So these are the classification. Non-Hodgkin's, low grade, high grade. So depending on this classification, some treatment protocol may vary. That is an important thing. But nowadays, according to immunohistochemistry, the treatment modalities may change in the treatment protocol. Now, Hodgkin's lymphoma classical features are lymphadenopathy. So, when we examine the lymph nodes, classical finding of any lymphoma is it is rubbery inconsistency. The nodes are rubbery inconsistent. They are discrete. They are not attached to each other. So, they are independent lymph nodes. When we examine, we can see easily it is mobile. And after some times it will be fixed. Whereas if you see tuberculosis, that's one of the strong differential diagnosis of lymphoma. You can get lymph nodes everywhere in the body, but they are actually connected together. They are called as matted lymph nodes. Especially in the cervical area, you can see multiple lymph nodes are stuck together, and they are called as matted lymph nodes. If you examine a patient with lymphadenopathy, there are a lot of differential diagnoses. So the classical example is if the patient coming with evening raise of temperature, weight loss, cervical lymphadenopathy or scalene lymph node enlargement, can be tuberculosis. The patient is having high degree fever, sweating, palpitation in the night time, and rubbery nodes are palpable, then it can be possibly lymphoma. The patient is having short history of fever, then cervical lymphadenopathy is there. Then if the patient develops rashes after amoxicillin, then it can be infectious mononucleosis. The patient is having prolonged weight loss for many years, then it can be HIV induced lymphadenopathy. Like that, various causes for lymphadenopathy is there. It can be infectious, it can be non-infectious like sarcoidosis. Sarcoidosis resembles tuberculosis, but it is a non-caseating lymphadenopathy, whereas in tuberculosis it is caseating lymphadenopathy, caseating granulomatous lymphadenopathy, whereas sarcoidosis is granulomatous lymphadenopathy, but it is not caseating. Like that, lot of differential diagnosis there. So in HL or Hodgkin's lymphoma, the lymph nodes are usually painless, mobile and rubbery nodes. That is very important. They are not matted, they are not stuck together. Mainly cervical area, mediastinal, axilla and growing lymph nodes are enlarged. Facial edema due to superior vena cava obstruction. That is not a feature of lymphadenopathy. Mediastinal tumors can produce this symptom, that is due to SVC obstruction. Subdiaphragmatic adenopathy is seen in some patients. Spread is contiguous. So from one group to other group, you can see the nodes are spreading, the malignancy is spreading. Hepatosplenomegaly is not very common in early stages of Hodgkin's lymphoma, whereas it is very, very common in non-Hodgkin's lymphoma early itself. So if the spleen, liver, Walde's ring, epitrochlear nodes are involved in initial itself, then we have to suspect non-Hodgkin's lymphoma. Extranodal involvement is also late in Hodgkin's lymphoma. Brain, bone marrow involvement can be there, but it is very late. B symptoms or constitutional symptoms, that is classical: fever, night sweats, weight loss, pruritus, anorexia. Pruritus especially increases with alcohol intake, fatigue. All these things are common in lymphoma, and classically night sweats, high degree fever, night sweats are very classical for Hodgkin's lymphoma. Same type of finding you can get in tuberculosis also, but tuberculosis, the amount of fever is very minimal. It is not very high degree fever. Low degree fever, constant fever, and sweating is classical in tuberculosis, whereas in lymphoma it is very high degree fever with night sweats. Now there is a classification for staging of lymphoma, that is stage 1, 2, 3, 4. Stage 1 is only one group of lymph nodes are involved: cervical, axillary, inguinal, mediastinal. Only one or two lymph nodes are involved here. But in stage 2, multiple lymph nodes are involved at one side of diaphragm, either above diaphragm or below diaphragm. Multiple nodes are involved, that is stage 2. Stage 3 is involvement of lymph nodes, lymph node regions or lymph node structures on both sides of diaphragm, both above and below the diaphragm. If it is involvement, then you can call it as stage 3. Stage 4 is disseminated, everywhere involved, like mediastinal involvement can be there, Walde's ring can be involved, axillary nodes can be involved, spleen, liver can be involved. So above and below diaphragm and other areas also involved in stage 4. This classification can be considered as Lugano classification, or previously it was called as Ann Arbor classification. Now you can see here the picture for classification. Stage 1, only one side of the diaphragm, one or two nodes are involved, one region is involved. Stage 2, above the diaphragm, more than one groups are involved. You can see here cervical and axillary nodes are involved. Stage 3, above and below diaphragm, inguinal and cervical nodes are involved here. Stage 4, it is extensive involvement here. Liver is involved, above and below diaphragm, lymph nodes are involved, bone marrow is involved. So that is stage 4. Again, stages are subdivided, substaging. A is asymptomatic. So stage 1A means only one side of diaphragm, it is asymptomatic. So stage is 1, 2, 3, 4, and substage is AB, E, S, X. So asymptomatic, B, presence of B symptoms, E, involvement of single extranodal site, S, splenic involvement, X, bulky nodal disease, nodal mass more than 1/3 of the intrathoracic diameter or 10 centimeter in dimension. So that is the substaging of the lymphoma. Now there are some favorable and unfavorable stages for the treatment. Stage 1A, 2A favorable conditions are given in the lower part. Stage 1 and 2 unfavorable condition. These groups include Hodgkin's lymphoma, that is only one side of the diaphragm above and below, but has one or more of these risk factors. It is bulky, that means 3 or more different areas of lymph nodes and tumor size is large. There is extranodal involvement, B symptoms and ES are high. These are the risk factors for stage 1 and 2 unfavorable conditions. That means these patients may or may not respond to treatment, and the response will be minimal. Advanced also, patient is having unfavorable stage for the treatment. Advanced means stage 2B, stage 3, stage 4. Now lab investigation we can see, one thing we should understand that this malignancy is originating from the lymph nodes, but these malignant cells can infiltrate the bone marrow and it can reduce the production of normal cells there. So patient can have anemia and symptoms related to anemia: weakness, cardiac failure, edema, or palpitations, dyspnea on exertion. All these things can be there. Then patient can have lymphopenia. Because of lymphopenia, he will be prone for many infections. So infections are very, very common in lymphoma. Thrombocytopenia can produce bleeding. Some patients can have eosinophilia also. ESR and CRP is highly elevated. That is because of the inflammation produced by these malignancy cells. LDH is elevated due to increased hemolysis. Many patients can have hemolysis also here. So LDH will be elevated. HIV ELISA should be tested because many patients with HIV can have lymphadenopathy without any other disease, and there are some diseases in HIV can produce lymphadenopathy like Mycobacterium avium complex, and so many other diseases can. And NHL is very, very common in later stages of HIV infection. So HIV infection should be ruled out in patients with lymphadenopathy, tuberculosis-induced lymphadenopathy, non-Hodgkin's lymphoma or Hodgkin's lymphoma. HIV should be ruled out. CT, PET MRI, FDG PET, all these things also can be done to make out where all these lymphoma cells are infiltrated. Or sometimes these patients can present with low-grade lymphoma, mild fever. We will not be able to make a diagnosis of PET CT or PET MRI, FDG PET. All these things can pick up in a case of pick up the diagnosis in a case of pyrexia of unknown origin. Bone marrow also can pick up these abnormal cells. Bone marrow should be done in a patient who is having severe cytopenia or infiltration of bone marrow. If we are finding, then bone marrow can also be done. Chest X-ray will show that mediastinal widening. Large number of nodes can be seen in chest X-ray sometimes. There will be focal infiltration in the lungs because of infections. That is also possible. CT chest and CT abdomen also can be done because sometimes mediastinal nodes are involved, sometimes abdominal nodes are involved, liver, spleen involvement can be there. So CT abdomen, CT chest can be done. Now lymph node biopsy should be done in all patients who is having enlarged lymph nodes. FNAC is adequate in a case of normal lymphadenopathy like infectious lymphadenopathy like tuberculosis and all, but whereas in patients who is having large lymph nodes, rubbery lymph nodes, if you are not getting proper diagnosis, then it is better to take a node for biopsy and rule out lymphoma. That is always better to rule out. In that you can see nodular sclerosing type, lymphocyte predominant type, mixed cellularity, lymphocyte depleted. These are cell types of the lymphoma, but you have to always see immunohistochemistry and what type of neoplastic cell expression is there, whether it is CD15, CD30, CD20, CD3, CD45, all these things should be checked by immunohistochemistry. So typical immunotype, classical Hodgkins and Reed-Sternberg cells, positive staining for CD15 and CD30, negative staining for CD3 and CD45. For nodular lymphocyte predominant NHL, Hodgkin's lymphoma, positive staining for CD20 and CD45, negative staining for CD3 and CD15. In NHL, CD20 antibody is positive, CD20 negative will be aggressive behavior and it may not respond to treatment also. Now we can see the adverse prognostic factors that we have seen unfavorable conditions like a patient have high ESR, high CRP, B symptoms, mediastinal mass ratio more than 0.33, bulky mediastinal lymphadenopathy more than 10 cm in diameter, more than 3 nodal sites, any extranodal lesions, age more than 50 years. Now when we diagnose NHL or HL, we have to use combination chemotherapy. Combination chemotherapy in HL is ABVD. that is doxorubicin, bleomycin, vinblastine, dacarbazine. So these are the drugs should be used in HL. So doses are given in this chart. You can use it as in cycles 1 and 15. You can see the chart. So this is the algorithm for treatment. The ABVD regimen we have previously seen. Another other types of drugs are benduximab, that is an anti-CD3 antibody that also can be tried. So you can see this chart for early stages ABVD cycle radiotherapy can be given. For advanced stage you add benduximab. You can see the chart. You can add benduximab with ABD in 6 cycles. So this is the treatment regime for NHL. Here we use CHOP-R, that is cyclophosphamide, doxorubicin, oncovin, prednisolone with rituximab. So rituximab is a newer drug. It's a biological drug. It's a monoclonal antibody, can be given along with CHOP regime. So this is the treatment protocol for NHL, aggressive NHL, CD20 positive. They require R-CHOP. R-CHOP is CHOP with rituximab. Rituximab, cyclophosphamide, doxorubicin, hydrochloride and vincristine or oncovin. So that can be given. So we have discussed about lymphomas. Generally lymphomas classified into Hodgkins, non-Hodgkins. Clinically, Hodgkins mainly affects the mediastinal nodes, cervical nodes and abdominal nodes, whereas non-Hodgkins initially itself it involves the extra-axial nodes. In emergency room, when we treat this type of patients, normally we see patients with SVC syndrome. That is one of the common presentation in mediastinal lymphadenopathy. SVC syndrome, they can have edematous face, edematous neck, non-pulsatile jugular veins. They may require steroids, immediate dose of steroids, otherwise they may go to complete obstruction and obstructive complications can develop. Other complications are this patient can develop severe anemia because of the bone marrow infiltration by these malignancy cells. So anemia should be treated. They can come with anemia, failure, peripheral edema, pulmonary edema. So they may be treated with NIV, Lasix and blood transfusion. Other complication is they can come with severe thrombocytopenia. So thrombocytopenia, if it is very less, the count is less than 10,000, or if there is a clinical bleeding, we have to give platelet transfusion. Neutropenia, patient can have neutropenic sepsis or febrile neutropenia. So according to the infection, like if there is a lung infection or abdominal infection, we have to select the antibiotic. But if there is neutropenia, severe neutropenia, we have to isolate this patient. We have to go for reverse isolation and we have to cover Pseudomonas or like organism in bone marrow suppression. You can give Substaging as a preventive drug. And if the patient comes with febrile neutropenia, we have to go for higher antibiotic like piperacillin tazobactam, meropenem with vancomycin. We have to cover both Pseudomonas and MRSA. So these are the routine complications come in lymphoma. And post-treatment, patient can have tumor lysis syndrome, electrolyte imbalances, and high degree fever, immune reactions. All these things are common even after treatment. So we have to be very careful in emergency room. This type of cases, whether it is Hodgkins, non-Hodgkins, they have lot of multitude of complications. They can come to emergency room. So basic idea about all these lymphomas are very, very important. Thank you.